my name is Molly McAway. I am a nurse and diabetes educator. I work for the Center for Diabetes Technology at UVA on the Artificial Pancreas Project. So I work a lot with technology and type 1 diabetes during the day. I am type 1 diabetic, I wear an insulin pump, and a continuous glucose monitor. So if you ever have questions about type 1s, I work with pediatric and adult patients during the day. What I do is I maximize their therapy so that when they come in for an inpatient trial or an outpatient trial, they've got insulin to carb ratios that make sense, they've got correction factors that make sense. I do a lot of pumping, and then I kind of do low tech here with the type 2s. We're doing just finger sticks and titrating insulin. So you guys play an amazing role here, and you don't know it yet, but you're going to make a huge difference in someone's life. For a lot of people, type 2 diabetes is a very scary thing and brand new. Does anybody have anybody in their life with type 2 or type 1 diabetes? Yeah, okay. If you don't, you probably will at some point. And no matter what practice specialty you go into, you're going to meet diabetes. So your knowledge here will benefit you long term. So one of the roles that you play is an active listener is when you're calling these people each week. Some of them, I mean, you may have to keep them on track. Some of them are going to tell you their life story, or tell you like everything that happened that day. And sometimes you just kind of remind them, okay, well, let's talk about your blood sugar. Let's talk about your diet. You know, what happened. But they're going to give you cues as to what's going on and what's wrong. For instance, one of our students was able to pick up on the fact that one of our patients was actually intellectually, mentally drifting. Something was going on with him. We couldn't quite figure it out. We were able to get some lab work back on him, and his blood sugar was 700. So we were able to call the rescue squad, get someone to him, get him admitted to the hospital for I call it HMS, which is probably HHMS, for the type 2 version of non-ketonic acidosis.
Osmotic hyperglycemia.
There we go. What she said. So, but we were able to get him help. So you may be the first line of defense if someone's actually having a real emergency. And some people will have what they think are real emergencies that they'll tell you about, and you know for a fact that they're fine. But you'll just listen, and you'll take it all in, you'll make some notes. I do review the charts about twice a month, and then I'll put Post-it notes through if I want to see somebody or if I want you to ask a specific question. Like, you know, there's keeps being, you know, high blood sugars no matter what you do in the morning. You know, you've titrated the dose, you've done all that. What are they eating after 9 p.m.? You know, if we find out it's like 2 ho-hos and a ding-dong, then we know what's going on right there. And then they can just come in and talk to me. And I'm here every Tuesday night. So I can work with you on any number of things. And also, Chris is going upstairs to get me a glucometer. I'm going to show you how to use the glucometer we use here. It is different than anything you can find on the shelf. I ran into that my first week here. I was like, this is not like any animal I've seen. It's very different. It's some Korean company, and the directions don't make a lot of sense. So it's not even translated to English all that well. So, I don't know. We get them for free. So, but you need to know how to work with them and troubleshoot them. When someone says, you know, my screen is fading, to know where the battery is to change it. Because sometimes they won't know this. And you just tell them to turn it over and flip the thing out. And, you know, just little teeny things can save a lot of time. The American Association of Diabetes Educators has 7 behaviors to focus on. And that's sort of what I kind of want to run through with you. In addition to titrating insulin, there's a lot of other factors that contribute to glucose changes. So healthy eating, monitoring, which can be blood sugar and insulin, problem solving, being active, taking medication, healthy coping, and reducing risks. So you actually play a role in all of these. Something else to consider is the education level and the health literacy of the person. We had a type 1 that came in, brand new diagnosis that night, did not speak English, and could not read or write English or Spanish. So that was particularly challenging. And he is being followed by our program. I'm calling him, or one of our physicians is calling him every week to try to titrate things. But some people can't read. And some people you will give directions to won't know what some of the words are that you're using. So try to take that into account. And if you're teaching somebody something new or you're asking them to change a dose, always have them say it back to you. Can they tell you what you just told them? And if they can't, you need to use different words entirely. The general education level in the United States, believe it or not, is in 8th grade. So keep that in mind. Fantastic. That's fine. So we will use this. All right, so healthy eating. You guys, I'm sure know what healthy eating is, but go back to the basics and ask your patients if they're having particularly weird things, like we were talking about, like the ho-ho ding-dong phenomenon, where someone's eating a weird snack at a time of day that's, kind of popping them up, or something that's not really considered all that healthy, or something that you would recommend a diabetic patient to eat. Just ask them, what are you eating? Or what does a typical meal look like for you? What are you doing for breakfast? Is it McDonald's? Or are you doing, a whole grain toast at home? There are big, big differences there. And sometimes just writing that down and leaving me a note can give me some information as how to help them in the future. And making small changes can be really big. So if you're talking about diet at all, and they're using, milk on their cereal, well, is it whole milk? If it is, because I've run into that a lot recently, just asking, hey, maybe you could pick up 2% next time you're in the grocery store. Just take that fat down by half and see what that does, because fat also decreases insulin absorption, the rate of insulin absorption. So especially if they're eating and they're taking a meal bolus with their meal, if it's a high-fat meal, they're going to spike because their insulin's not going to be able to get absorbed as well. So that's important to remember. So we like low-fat diets and good whole grains.
Another easy one is soda.
Mm-hmm.
Soda is so
Diet
evil,
soda.
and you'd be surprised by how many people are drinking it and what a difference you can make by their calorie intake with soda alone.
Yeah, one can, not the bottle, but the can of regular Coke has 9 tablespoons of sugar. So you can really decrease that by going to diet soda, or even doing half and half for a little while if the person's like just completely protesting, giving up that regular soda. So you can do a lot there. You may also be doing some troubleshooting on the phone with blood glucose monitoring. We discovered we had a patient who was giving the same numbers over and over again. And the statistics, it's really statistically impossible for that to happen, like 3 weeks in a row. So we had her come in, and I worked with her, and I realized, she was doing everything correct until she put the blood on the strip. She was pressing the center button before it had a chance to actually run the test, and it would just reflect the previous value that she had. So, it all looked very normal, when in fact, she was actually in the 300s, and she was reporting things like 93 and 109 and 121 over and over and over and over again. So, be suspicious of that.